You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for November 13th, 2020. This week, COVID vaccine, thrombolysis and stroke, industry payments to doctors, some notes on the AHA, specifically including some comments on AF ablation. Now, I haven't given total COVID numbers in a while, but there's 52.5 million cases worldwide. 1.3 million people have died. The U.S. has 10.7 million total cases and 247,000 deaths, nearly 250,000 people. I thought these numbers were relevant when talking about the vaccine. So to sum up, yes, it's still bad, and in the U.S. it's definitely worse. As of yesterday, the moving 7-day average was still going higher. Hospitalizations are increased and the number of deaths has nudged up. Now, the differential between cases and deaths is still larger than it was early in the pandemic, but still, this is not a good situation. So let's talk about the COVID vaccine news. Before I tell you about it, let me quote just one sentence from the Medical Conservative paper. Quote, "The medical conservative sees benefits from the confluence of interest between profit motives of industry and progress in research. Medical conservatives do not oppose industry-physician collaboration." So with that as background, very early Monday, well before the markets opened, Pfizer released a short press release of their phase 3 vaccine trial. Now, this candidate vaccine does require 2 shots about 3 weeks apart, but still, this was hugely good news. The vaccine was 90% effective in preventing COVID-19 in people without evidence of prior infection. This was a first interim efficacy analysis look. Now recall that the DSMB look at the data was going to be after only 32 of 164 cases. That was controversial. There was negotiations with FDA, and then apparently there was an agreement to look after 64 cases. But by the time everything got done, the first look had 94 cases. So 94 out of 164 gives you a decent feeling about where this is going. And so 90% efficacy is quite good. Because if the goal was having an efficacy greater than 50%, even if the next 70 cases didn't perform as well as the first, the 90% efficacy this far along makes it likely that the vaccine is going to get over that bar of efficacy. Now, this study was big. It enrolled nearly 44,000 people and 42% from diverse backgrounds. And we know that almost 39,000 people have received their second dose of vaccine. The press release said there were no serious side effects, but there was no data to support this. Preclinical studies have indeed found that there's a significant immune reaction after the shot. Things like fever and aches are more common with the COVID vaccine than with the influenza vaccine. Now, also problematic with this vaccine is logistics. It has to be stored at very cold temperatures, and this will make distribution challenging. The Pfizer vaccine wasn't the only good news. 2 other pieces of good news. One was that Dr. Fauci announced that they were very close to a similar look at Moderna's vaccine trials, and that he expected similar efficacy. Also, researchers in Moscow announced this week that the Russia Sputnik V vaccine also had a 92% efficacy. However, this was based on only 20 cases after 16,000 volunteers, so not as far along as the Pfizer vaccine. Final piece of good news is that there are at least 10 vaccine candidates in late-stage trials. But of course, you all know I would list the reasons for caution. We don't know how the vaccine performs in reducing serious cases of COVID. We don't know how it will perform in the most vulnerable. And in the trial, since the vaccine creates an immune reaction, it is likely that participants knew their treatment assignment and they could have acted accordingly. Without a lot more published data, we don't know if the vaccine could increase the intensity of infection. That's an important factor. We need more data. Safety is a huge unknown. The Pfizer trial is expected to be done in 2 weeks, and that'll give us short-term safety data on about 22,000 people, which sounds like a lot. But this vaccine could be given to millions, if not billions, of people. It wouldn't take many cases of a severe but rare reaction to change public perception. And on the matter of safety and low occurring events of a highly efficacious vaccine, I highly recommend my friend Lisa Rosenbaum's New England Journal of Medicine piece. It was called Cardiology, and it was regarding the dengue vaccine and its backlash in the Philippines. It's really pertinent reading these days. Next topic, thrombolysis for later presentation acute stroke. Now, The Lancet has published an individual patient level analysis of 4 randomized trials that studied alteplase use in patients with an unknown time of onset of symptoms. Now, recall that the seminal stroke trials required short duration time of onset before giving thrombolysis. This current meta-analysis included 4 trials, Wake Up, Extend, THAWS, ECOS-4, and each of these trials used some form of MRI or CT imaging to determine eligibility for the drug. The 4 trials provided individual patient-level data for 843 patients, about half in the drug arm, half in placebo. Now remember, 3 of the trials included did not show statistically significant results in the primary endpoint. And the one that did, the Wake Up trial, was stopped prematurely, and it had 3-fold higher rates of death and a 5-fold greater rate of intracranial hemorrhage. Now, as is customary in these trials, the primary outcome was a favorable functional outcome defined by the modified Rankin score of 0 to 1. That indicates no disability, and this is done at 90 days. In the meta-analysis, this was achieved in 47% of patients who received alteplase versus 39% of those in the control groups, giving an adjusted odds ratio of 1.49 and a significant p-value. In a secondary outcome, looking at modified Rankin scale of 0 to 2, which includes some disability, alteplase still looked better with an odds ratio of 1.50. The problem, of course, is that these benefits, which are measured in this modified Rankin scale, is highly subjective. There's inter-observer variability in the modified Rankin scale, and it has to be balanced against 2 highly objective bad outcomes. Number 1, death at 90 days occurred in 6% of alteplase versus 3% of placebo. That's an odds ratio of 2.1. Symptomatic intracranial hemorrhage, 3% alteplase, 0.5% placebo, 3.5-fold greater odds ratio. Now, my comments on this is that this is a well-done meta-analysis, but the interpretation is a matter of opinion. Alteplase does help reduce a few more people get to a modified Rankin scale of 0 to 1. The absolute risk reduction of 8% translates to an NNT of 12. However, alteplase also kills a few more people. Absolute risk increase, 3%. Number needed to harm, 33. Almost 40% of people in the control arm were modified Rankin scale 0 to 1. Almost 60% in the control arm were modified Rankin scale 0 to 2, just mild disability. So if you inject saline, 6 out of 10 people eligible for alteplase would still remain independent after their stroke. And they'd be 2-fold less likely to die and 3.5x-fold less likely to have a catastrophic intracranial hemorrhage. If it were me, give me the injection of saline. Next topic is industry payments. JAMA has published 2 papers on the exchange of money from industry to doctors. The Heart.org Medscape Cardiology has both news coverage and commentary from the amazing communicator, Dr. F. Perry Wilson from Yale. The first paper, in research letter form, looked at trends in industry payments from the CMS Open Payments database. Open payments began in 2013, the idea being to increase transparency of what docs make from industry. Now, this was a truly big data survey, about 800,000 docs. In 2014, 52% of doctors received at least one payment, and in 2018, that had decreased to about 45%, but still nearly half of doctors get money from industry. Over the 4 years, 90% of physicians who accepted payments received less than $10,000. The median amount was small at $215. Those doctors receiving more than $50,000, though, accounted for 3.4% of physicians receiving payments, but this was 82% of the value. For these high-earning doctors, annual payment values increased or remained stable over the 4-year period. F. Perry Wilson had this comment, quote, "Pharma spent about $9 billion paying U.S. physicians. Almost half of that went to physicians who received more than $500,000 a year from industry. Industry, therefore, is not an equal opportunity lender." Now, does all this matter? Of course it does. The second study, also in JAMA from the group at Yale led by Jephthah Curtis and Joe Ross, looked at the correlation between industry payment to ICD, defibrillator implanters, and the devices they put in patients. This was another big study of nearly 150,000 ICD implants, about 4,400 docs using devices from the 4 big device makers. The group also used the Open Payments database and combined it with the NCDR data. Some key findings. 94% of ICD implanting doctors received industry money. 94%. The median payment, $1,200. And this, the main finding. Quote, "Patients were substantially more likely to receive devices made by the manufacturer that provided the largest payment to the physician who performed the implantation than they were from each other individual manufacturer." Okay, what to say about this? First, a disclosure. In 2016 and 2018, I lectured at Sunit Mittal's New York City conference sponsored by Medtronic. One lecture on risk factor modification before AF ablation, and one lecture on getting device data to patients. I made my own slides. Nonetheless, I was paid by Medtronic. Now, this came up because after becoming a HIS bundle pacing advocate, I was actually accused as being biased for Medtronic because of these payments for these past lectures. I vowed to be conflict-free from now on. The last 2 years, I've not taken any money from industry, and I plan on continuing that. And I agree with my friend Vinay Prasad, who advocates this approach. The problem with industry payments to doctors, even when modest monies are exchanged, goes back to Stark's tripartite of conflict of interest. I'll link to a nice paper from Daniel Goldberg from the University of Colorado. Stark outlined the first issue is the antecedent act. Such acts might consist of a meal or a sponsored talk, attendance at a continuing professional education event sponsored by industry, or even a visit from a sales rep. These antecedent acts give rise to the second stage, which is states of mind. The antecedent acts tend to build a favorable state of mind or disposition. Look, humans are social, and gifts promote social adhesion by facilitating reciprocity. Now, once there are favorable states of mind, there is a behavior of partiality. This is glaringly obvious. You see it in things like the CHIP designation in interventional cardiology. If you go to a course sponsored by industry, you can get the designation of being a complex, higher-risk indicated procedure operator. Alas, doing said complex procedure also includes using expensive tools that were promoted at the meeting, things like Impella. We have many examples in EP. Fellows courses sponsored by industry are there to create antecedent acts, then favorable states of mind, so as to induce behaviors of impartiality. EP doctors feel pressure to do all the latest procedures involving all the latest industry products. I am sure this happens because it happened to me when I was a younger electrophysiologist. Now keep in mind, I am not against working with industry. You have to in cardiology. And as I began this podcast, industry will likely get us out of this pandemic. I would also add that industry is not evil. They have one purpose, and that is making money. And it would be wise of us to consider this in our assessment of the evidence. Okay, final topic, a few more notes on the AHA coming up. I record this podcast on Friday morning, and thus AHA is going to begin in a few hours. First, on the AF front, there are a number of worthy studies. I'm particularly looking forward to the mSToPS study. mSToPS is looking at 3-year clinical outcomes. It's a nationwide randomized pragmatic clinical trial of AF screening. Back in 2018, the mSToPS researchers reported in JAMA that an ECG monitoring patch used in older patients led to higher rates of AF diagnosis, more anticoagulant therapy, and increased healthcare utilization. What's interesting about this coming study is that they say they will report on outcomes. Recall that most screening studies, including a number of more you'll hear about at this week's AHA, all include AF incidence as the primary outcome. But you know that screening must do more than pick up disease and send people into the profit-driven healthcare system. Screening must reduce the chance of dying or suffering. These are the only outcomes that matter. All right, on the AF ablation front, my friend Jason Andrade from the University of British Columbia will present results of the multi-center early AF trial. This is an RCT of cryoballoon ablation versus meds for the initial rhythm control in patients with yet untreated AF. The primary endpoint here is first determined recurrence of atrial tachyarrhythmia. Recall also that another friend of mine, Osama Wazni from the Cleveland Clinic, he presented very positive results of a similar trial at ESC. This was the STOP AF trial of cryoballoon ablation versus meds, again for initial rhythm control. This study found that cryoballoon ablation was far superior in reducing the primary endpoint of freedom from AF. Thus, it's likely that the Canadian early AF trial will also show a reduction in AF episodes. Both trials are at least partially sponsored by Medtronic, a company whose non-nefarious interest is in selling more cryoballoons. As I wrote in my preview piece, early AF ablation worries me because AF can abate on its own, and all the risks of an ablation procedure are definitely small in absolute terms. There's serious asymmetry. The asymmetry of having an atrial-esophageal fistula or a stroke are substantial. Now, I have no doubt that early AF ablation with either RF or cryoballoon will beat drugs. The literature is full up with studies showing that ablation reduces AF episodes versus drugs. The question is, how good a marker is AFib as a surrogate? I mean, we have Cabana, which shows no difference in heart outcomes. This was done in the best centers in the world. Friends, I continue to believe that electrophysiology is going down the wrong road with AF ablation. Yes, of course, it has a role in highly selected patients. But the core problem is that AF is very often a marker of atrial disease. The real treatment ought to be directed at that which causes the atrial disease: obesity, alcohol, sleep apnea, stress, hypertension, diabetes, even excess marathon running or cycling. We don't treat patients with bacterial sepsis with just fever-reducing agents. We treat them with antibiotics. Likewise, with AFib ablation, we ought to be treating the things that cause disease in the atrium. Okay, another highlight of AHA will be hearing about the new mineralocorticoid receptor drug called finerenone. This is a novel and non-steroidal MRA. At the recent Kidney Week meeting, finerenone resulted in a lower risk for chronic kidney disease progression and CV events in the Fidelio DKD trial. This RCT enrolled more than 5,700 patients with chronic kidney disease and type 2 diabetes. The primary endpoint of this trial was a renal composite, but there were secondary outcomes that included CV death, MI, stroke, and hospital admission for heart failure. The CV outcomes we know trended positive for the drug, and at the AHA meeting, we will hear more about this data. Now, the optimistic aspect of this drug is that it seems to have lower rates of hyperkalemia. That's good. And of course, its non-steroidal nature means that there's no anti-androgen side effects. Final point, I sound like a broken record, I know, but we'll hear results at AHA of 2 trials of another SGLT2 inhibitor, this drug called sotagliflozin, and both these trials will enroll patients with diabetes, and both are cardiovascular outcomes trials. And again, if you think from a Bayesian perspective, it would be hard to bet against any SGLT2 inhibitor drug in high-risk patients. Okay, so that's it for this week in cardiology. As always, I'm grateful that you listened. And friends, remember, if you like this podcast, please take the time to give us a rating or even write us a brief 1 or 2 sentence review. It just helps others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.